Hi, folks. Just before Dr. Natteru gets started again, I wanted to answer a couple of people, and I suspect this is the whole class, questions about the first exam. I'm cleaning up the questions from my exam bank. I should have it up sometime next week. It's actually going to be on Canvas as a set or a series of quizzes. You can take them in any order, and there'll be basically 10 questions a quiz. As usual, 90 seconds allowed per question, so 9 minutes per quiz. You'll get immediate feedback on each quiz, so as I told the last person who stopped up, if you screw up on one, it gives you a chance to say, maybe I should study a bit more before I tackle the next one. They'll be open from whenever I can get them up next week till the end of exam week. So when you take them is completely up to you, okay? And you do not have to take it all at one time. So if you want to take one quiz today and another tomorrow and another the following day, that's fine with me. I don't care. All right? Make sense? Yes. I'll have to figure it out, I'm sorry. But I'll post it. Let me do the calculations this weekend, and I'll post it as an announcement, okay? Hey, I can do some of this stuff in my head, but I've been out of the lab for a long time. It takes me longer to come up with math in my head. All right? Okay. Okay, folks, on with the presentation. Oh, wait. Wait a sec, sorry.
Hello? So, too loud. Okay. All right, so let's move on with our next case. We have 4 more cases, 10 minutes each case, maybe 7 minutes each case, okay? So the 41-year-old right-handed woman collapsed on a soccer field during a hot summer day. Remembered being at the field, watching her son play, walking towards the other side, and then she lost consciousness. So you immediately know, aware or not aware? Not aware, good. And then that's the next line. She was unaware of what happened. When she arrived in the ED, there was no witness report, vitals and exams normal. Normal, this never happens. At least at UMMC ER, we get a CAT scan, they call neurology, we admit, and then we get an EEG. But EEG never happens in the ER unless there's concern for status epilepticus. So, what's going on? Go. Don't be biased by the lecture that I'm giving you. There might be a trick question. Overwhelming response for seizure. All right. Out of the 68%, right? What made you think it is a seizure? Just because I'm talking about seizures? Sorry, that's not the answer. But who are the 32% people who said syncope? What made you think it was syncope? It was a hot day, good. It was just a usual day in Mississippi, in summer? Okay. What else? Were there any signs that made you think it was seizure? Okay, all right. Let's move on. You'll know the answer soon, okay? So during follow-up, because this patient came to neurology and we took her to an epilepsy center, it was revealed that patient had asked a witness who was there at that point in time and who described that the patient collapsed to the ground, became rigid, and then started convulsing. Okay? Now you know it's pretty obviously seizure, but just from that first slide that I gave you, I cannot be on either side. I can't say it is a seizure, I can't say it is a syncope, but I would be more leaning towards syncope because that's the presentation with which they came. And this is going to be very common in your practices if people are doing internal medicine or ER or neurology. This is the most common question they come in. They say seizure versus syncope evaluation, okay? So when this happened, started convulsing for more than a minute. Afterward, patient appeared confused and incoherent. So that is the postictal phase, correct? Then the patient remembered on further questioning that she had a really feared feeling of sudden strong fear. So in your chart, the ILAE classification, what can you check with this? Sense of fear for about 10 seconds. Could be autonomic, could also be sensory. Yeah, because that sense of fear that's coming in. So that's, could be autonomic, could be fear, could be sensory. And then the patient had this sudden distinct fear sensation a few times, about 1 to 2 times per year over the last 4 years. Somebody asked me during the break as to how do you differentiate whether it's a focal, it's a generalized, as to what goes on. The diagnosis is not so obvious on your first visit. And this is what I want to tell you guys, that it's okay to not know if it's a seizure or syncope, because that's what we are training for in neurology, medicine, wherever. The first outlook is, yeah, you get the history from the ER is what EMS tell them, which is 4 lines basically, which is pointless, literally. No offense to ER people, but that's how it is. When this happens, history is really important to ask the patient as to what exactly happened before and what do you remember after. And that's where this whole case scenario comes into picture. So thing is, she's had this sense of fear, but she's able to calm herself down with a few deep breaths. During some of these episodes, she's told her husband that she felt weird, and when he checked on her, she always seemed to be able to respond. Now, how many of you think it's a seizure? How many of you think, wait, hold on, yeah. What's the poll? What's the verdict? Okay, 5% for faking it, 11 for anxiety, 4% for syncope. Okay, all right. Most of you got it right. It's a seizure, but for the people who thought it was syncope, I understand why. Also, a few people thought it's anxiety. Yes, I understand why, because if you had to ask me until PGY 1 year, I used to be like, oh, this guy's talking while he's having a seizure. It's faking it. If I was in your spot, I would have taken D, faking it, okay? But because she's able to calm herself down when she's having this sense of fear, which you're not supposed to do it if you're actually having a seizure. But that's a myth, okay? You can at times control. Now, we don't know if it was true anxiety or it was actually a seizure that was causing it, because she had the sense of fear. The sense of fear that's coming in is a true seizure phenomena. But that the anxiety coming with it, that's not. That's basically when you're fearful, you're a little anxious, right? Okay, that's why I made this. All right, coming to the neurodiagnostic, anything that you see abnormal there? Again, right side, left side. Okay, where? I see people pointing fingers, but I want to just give me an idea if it's on the right side or left side. Right side, bright white spot. This one, a little bit higher. This one, to the left. This one, very good. That's the problem. You see that? That's the temporal lobe, temporal lobe, temporal lobe, temporal lobe. Even if you don't go to neurology, if you or just look at an image, they should be symmetric. God's made it that way, okay? Most of the times, all right? But when you don't find symmetry is when you're worried, and that's when you need to look. And this is what this was going on with that patient. All right, so brain MRI showed a signal abnormality, blah, blah, blah. EEG was normal now. It can happen. EEG will not always give you seizure, because it's, when you do a spot EEG in the ER, which is just 20 minutes, at that point of time, it's a snapshot at that point of time. It won't tell you what happened 2 days ago. You got a question? Oh, okay. Sorry. No. Okay. It won't tell you what happened 2 days ago. It won't tell you what happened 2 days after. But it kind of tells you what is going on at that point in time. So EEG, in this case, was normal. So if you have to classify this, what would you classify this as? First, is it under this or this? Okay, I'll simplify this. Don't work. So there was an emotional aspect because of the fear, yeah? And it was focal to bilateral tonic-clonic. Yes? Yeah, generalized is usually unaware. It's always generalized. Whenever you have generalized tonic-clonic seizure, they're always unaware. Focal is you have to divide it. Now in this case, why I said focal to bilateral tonic-clonic is the fear phenomena that she had was here, and then she had right? So started, can we start the Mexican wave again? There. Focal, start first, then move. There. So that, yeah, it takes some time to spread to the other side, but seizures is pretty quick, okay? All right. So if you have to describe it, it was right temporal lobe epilepsy with symptomatology of psychic aura, which is the sense of fear that was coming in, and preceding a bilateral tonic-clonic seizure. So it is focal aware emotional seizure progressing to bilateral tonic-clonic seizure. Yes? Yeah, they can start off as that. Yeah, but most of the times with this new classification, what they're leaning towards is if you get a florid manifestation, it's the whole brain firing. But if you get one part of the brain firing and giving you aura, that's more likely focal, generalizing later on. Okay? All right, the third case. A 13-year-old girl presented for evaluation after experiencing a generalized tonic-clonic seizure. So the answer is pretty obvious in your chart. The ILAE, she fits under generalized tonic-clonic seizure type. But this occurred in the morning upon awakening. History revealed that she would often drop her toothbrush in the morning. Any guesses what seizure type is this? There you go. All right, I'll rush through it. So myoclonic, I put that tonic-clonic initially because she had a generalized tonic-clonic seizure, but if you had to classify it, it would be myoclonic, tonic-clonic. It's just a combination. Oh, sorry. Yeah.
What time did you make until last night? I'm exhausted.
Oh, it was so late, I'm so tired, but just want to get that coursework done for next week.
This will get you going again.
Thanks, Dad.
Just too dramatic, but yeah, that's fine. All right, so that was myoclonic seizure, yeah? So on neurodiagnostics, which is the EEG, anything abnormal there? One side, both sides? Throughout? Everywhere, good. So everywhere. Okay? All right, so that's a spike, wave, spike, wave, spike, wave. Okay? So generalized spike wave discharge. USMLE step 1 or step 2, it might show up. Okay? Just telling you. That is suggestive of myoclonic epilepsy. I think in your case, the questions that can come up is juvenile myoclonic epilepsy would be the question for you guys. I don't think they ask you about other types of myoclonic epilepsy. Juvenile myoclonic epilepsy, look for a patient who is young, wakes up in the morning and has a complaint of dropping things, and sometimes can have generalized tonic-clonic seizure, okay? All right, so this is basically explaining non-rhythmic. For some reason, it's always a toothbrush that you drop, because when you wake up in the morning, that's the first thing you reach for. I think so. And then myoclonus that may represent a seizure manifestation, as in infantile spasms that I told you about, the kids who have that. And then is myoclonus always pathological? Yes, no? Show of hands for yes. Really? Okay. No? Okay. People who didn't raise their hands, are you undecided whether it's a yes or no? You don't understand the question. Okay. So if you see a myoclonus in somebody, is it always pathological? That means, is it always a disease that they're having is why they have a myoclonus? No. Okay. So I've felt this. I know you guys have felt it too. When you try to study for your step or shelves or whatever it is, at night, when you're reading, when the subject is too boring, you tend to doze off, yeah? Okay. Have you ever noticed that while you're trying to do that, at some point you'll just wake up startled? You have. What is that? That's myoclonus. It's called hypnic jerk, okay? So hypnia means sleep. And when you're going to sleep, and I feel it, because in morning report, after my call, I'm sleeping. And I feel an attending is pointing or calling out my name, and that's what happens. And I'm like, just wake up. And that's a startle response, which is a myoclonus, and it's physiological, okay? Not every patient who has a myoclonus is pathological, all right? After that fact, let's move forward. All right. So what is it finally? Generalized epilepsy syndrome, likely juvenile myoclonic epilepsy. Key to recognize this on the USMLE: early morning, fidgety, fumbly behavior, dropping things, younger patient, okay? Okay, case 4. We're rushing. I just have 2 more cases after that. This is a 5-year-old female who's brought to your office because of episodic blanking out, yeah? So, any guesses? There you go. Okay. All right. So it began a month ago. Patient had episodes in which she abruptly stops all activity for about 10 seconds. So if you had to dissect this, you would say there was behavioral arrest, right? Because there was staring for 10 seconds. And then she would remain motionless with occasional fumbling hand movements. Now you might question here, you're describing all features of focal, but then you had told us that absence is generalized. Yeah? But you see, generalized seizure is actually encompassing many focal seizures together. And this is what it is. Okay? She has about 30 episodes per day, and that's not uncommon. In fact, I had seen a patient who had 70 spells per day recorded on the EEG. Imagine leading a life like that as a child in a school where it's so competitive. Like, I have my 8-year-old niece, like, her bag is so heavy. I can't even imagine, like, what do they teach in school these days? And having absence with it is just ridiculous, okay? Then that's why what's important is to diagnose it and not just blame the child or kid, saying lack of attention, lack of awareness, and stuff like that, okay? All right, so past medical history, I'll just skim through. Important part in this slide is hyperventilation. That's another USMLE question. Which seizure is brought on or aggravated by hyperventilation? It's absence. We don't know why it does that, but hyperventilation brings upon absence. And it's a very characteristic pattern on the EEG. Remember we spoke about myoclonic epilepsy and I said generalized spike wave discharges? In absence, you're still seeing generalized spike wave discharges, but the important part is this is a 1-second duration, right? How many can you count in that? How many peaks are you seeing? 3. 3, I can argue 3 to 3.5. So that's your question for USMLE. 3 hertz, spike and wave, generalized discharge, seizure brought upon by hyperventilation, right? Absence. Okay. There. Sir, would you click on the...
This girl has absence seizures, and you will see her have one while she's talking.
Because he can be as heavy as ever.
And there's a real blankness, a vacant look in the eye, and then all of a sudden they're right back with you and able to engage.
Sorry? Absence seizures can be mistaken for daydreaming. One of the hallmarks of absence is that the seizures happen many times in a day. Sometimes they're so fleeting, they're easy to miss. This boy is having frequent but very brief episodes. You can see his eyes flutter up. He's out of touch. Then he becomes fully aware again.
Clear? Okay. All right, so this is absence and typical. All right, fifth case. This is a 49-year-old man. He was referred for evaluation of seizures. He reported the onset of generalized convulsions approximately 9 months ago. When he came to us, his wife described that each episode consisted of a loud vocalization, like he would have this, oh, and then the seizure activity. Yeah. Then you have stiffening and generalized shaking, nausea, and sometimes a feeling of deja vu. Okay. But the events before the events, but otherwise did not remember much before the episodes, and that's pretty common. Amnesia is very common in seizures because sometimes they don't remember what happened. Their distant memory, they remember what happened 3 days ago, but if you ask them what happened a little bit prior to the seizure, they're like, I don't know. That's in the postictal period, just right after the seizure. But you give them some time, and then you ask them the question, they will be able to give you a history, okay? Now, he would be confused briefly upon awakening, and his episodes continued despite him being on 3 anticonvulsant medication, with an average of 2 seizures per month. What's going on here? Let's classify this. What seizures, where would you put him on? Here, 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 or here? Generalized? Does everybody agree with generalized tonic-clonic? Yeah? Okay. All right. So we'll see what happens. What else was there? There were some cognitive features in terms of he was not able to remember. Yeah? The outpatient EEG and MRI were normal. Now, he had a history of aortic stenosis and sleep apnea, but no known epilepsy risk factors. He was admitted for inpatient video EEG monitoring, and the EEG after that was normal. Now, what is our thought process? What are we thinking? So normally, all our cases, which I've shown prior to this, neurodiagnostics was your key, right? You see something abnormal there, and they're like, oh, I know this. But here, neurodiagnostics is normal, and that's about 50% of the times, that's the situation in our world. The diagnostics is perfectly normal. And then you look at, we wait or pray for them to have a seizure so that we can figure out what exactly is going on. There will be days, 7 days at a stretch, and no seizure. So you will do all procedures to try to bring a seizure on, like you sleep deprive them, you ask them to hyperventilate, photic stimulation, like you throw flashes of light, nothing brings it on. What do you do then? At that point of time, you're like in a dilemma. Do I discharge this patient, say he's faker, and just push him out? Or do you do something else, like something more? We don't do much of it here at University of Mississippi, but I'm applying for an epilepsy fellowship. So at some of the programs where I've been to, they use subdural grids, okay? So it's called basically brain mapping. There's a new terminology, new method of where they can do is stereo EEG, where the neurosurgeon places strips of electrodes. The normal EEG that we do here normally is scalp. Right on the scalp, you put a bunch of electrodes and they pick up brain activity. But if you can't pick it up from the top, because this part can only pick up the superficial part, What if the seizure is coming from deep? What do you do then? At that point in time, you get the neurosurgeons involved, and they place some grids, or stereo EEG is a method with which you can localize further. In this case, what do you think is going on? You can type it out. That's a little puzzling. See by the responses there, just 5. Okay. That's fine. Low oxygen to the brain, syncope, hypoxia, okay, psychogenic, non-epileptic seizures, insular cortex seizure. Good. That's a good bunch of differential. I don't see generalized tonic-clonic seizure here anywhere. Did I miss it? Okay, yeah. Nobody thinks it's a generalized tonic-clonic seizure that we are having difficulty to capture? No? Okay, all right. So we'll see what this is. It's NES. It's non-epileptic spell. Basically, things that can mimic a seizure. They can look like a seizure, but they're actually not a seizure. Let's play the video and you will see why. So the same guy who was in the EMU, it should pop up.
Can you tell me your first and your last name? I want you to remember 2 words, okay? Yellow bag. Can you show me 2 fingers? Show me 2. Can you point your finger to your nose? Can you raise your left arm for me? What's your name? Do you know where you are? In the hospital. Do you know the name? This University of...
All right. So, any questions on why this is not a generalized tonic-clonic and why this is non-epileptic spell? Yes. Correct. So no postictal phase. So the way to differentiate between generalized tonic-clonic seizures and these days there's a terminology for this, it's called functional neurological disorders. Okay? One part of that is non-epileptic spell. So what happens is, in Mississippi, I've seen it very common, and especially in my last 2 years here. A lot of people go like, he's a faker or she's a faker. In terms of, you've heard of the term pseudo-seizure? Yes? Most of you have? Okay. With the term pseudo-seizure, it's actually used synonymously with non-epileptic spell. It just... Exactly. And it's one of my pet peeves as well, because it's not fake. To be honest, it's not fake. Maybe out of 100 cases that you see, 1 or 2 might be fake. But in all honesty, what they have is an underlying comorbid condition like depression, schizophrenia, post-trauma stress disorder, traumatic brain injury. And that's what is manifesting. The stress in the body is manifesting as this. In simple terms, if you have to describe, I know Dr. Paul can throw more light on this, but from a neurologist's perspective, I can say that it's more of an acting out of your own body without your knowledge. Make sense? And this is what looks like a psychogenic non-epileptic spell. The keys to, the things to identify in the history when you're asking a patient is, what is the type of seizure they're having? Most of the time, you will find that there's an audience when the seizure is happening. It's never, or I shouldn't say never, it's less frequent for them to have a seizure when they're all by themselves. It's usually when there's an audience around them for attention, for, caring, all of that stuff. But the questions or the exam when you're doing, exam is relatively afocal. Like, the neurological exam is completely normal. And at that point of time, you're like, okay, try to ask more history. One of the students, I think Brett, yeah. So he brought up an interesting thing. If you guys have not seen the show, there's a show called Diagnosis, yeah, on Netflix. I'm not publicizing it. What he told me, I'm telling you. So there's a case apparently on that show where there is a patient who was diagnosed with or had seizures like this, and his heart would stop right after the seizure. And then at that point in time, you're like, oh, this is actually a true seizure. But the EEG did not have any correlate in terms of the activity that's happening to the brain. So they thought it is psychogenic non-epileptic spell. So if you guys have not checked it out, he recommends, not me, that you watch that episode. And he can tell you which season, what episode, yeah, he'll pass it on. All right, so exam-wise, when you ask them, like, how was the seizure? Most of the time they describe it like this. Head bobbing, arching of the back, jactitation. Jactitation is tossing around in the bed, okay? So that's in the thick of the things, like when you're seeing it, you're not experienced, you're like, oh, this is a seizure. And I don't blame you for it. It's just with experience that you know, and sometimes we get confused that we think it's non-epileptic and turns out to be epileptic, or sometimes it's epilepsy and turns out non-epileptic. So there was this, I cannot tell you the details more than just these two lines. When I was on EMU, which is the Epilepsy Monitoring Unit, there was an 18-year-old who had come in for the past 2 years. He's been bounced from provider to provider, saying he's a faker and, he's been acting out and all of that stuff. We bring him in, looked very fake, to be honest with you, looked very fake. But then we connected the leads and we looked at the EEG. He'd actually had frontal lobe epilepsy. He had seizures coming from both of his frontal lobes, and the way it would manifest is hyperkinetic. He was actually bicycling. And then at night, he would get up out of his bed and walk on the floors in his sleep. And at that point in time, we're like, that's not true. But it was, okay? So we thought we can get fooled as well. So I don't blame you if you're fooled by what's a true, what's a not. But try to know as to what could be the exam features that could differentiate it, okay? Clear on psychogenic non-epileptic spells? We'll see. All right. So this patient actually had typical events that were associated with cardiac asystole, just like the case Brett had described, and that's what it is. We need to bring that down. Okay. So what do PNES looks like? They can mimic a convulsive seizure, thrashing movements of the entire body, arching, responsive during the event, like this guy. When you saw the video of the guy, the nurse came in and said, can you show me 2 fingers? And he put up this. Said, touch your nose. He did that. Okay? And usually it's a long duration, but in his case, it was pretty short. And then sometimes a non-convulsive seizure can also look like PNES, like just staring, difficult to distinguish. Okay? How big of a problem is this? Yeah, that's the numbers. Okay? That's, I think, 4 medical students in this class with their student loans. Yeah? Or 5, maybe. Yeah, so that's that. Now, the question here is to believe the patient or not to believe. That's actually not the question. Okay? Always give the patients the benefit of the doubt. If they are having spells, yes, it's one additional note for you to write, but you get to learn a little bit more. People who are going into ER, you don't have to worry about this, but all other specialties, please take note of this. Things here is ictal cry. weeping or screaming. Duration is very less. In epilepsy side, it's less than 3 minutes. On this side, it's more. They're forgetful of what's going on, and sometimes it's variable. Okay, 10 to 30% of the psychogenic non-epileptic spells, patients actually have existing true epilepsy. In fact, it was already confusing. Now I've confused you even more. It's not me, it's the stats, okay? All right, so this was a paper that I had written when I was in 2017, because this was a guy who came in as obstructive sleep apnea, undiagnosed, and in sleep he would have these ictal event where his heart would stop breathing, beating, and he would stop breathing, and they thought that that was a seizure because when it happens, it's like, so he kind of wakes up. Now, how many of you are aware of obstructive sleep apnea and what does it do? Hands up. One. Okay. In simple terms, imagine you have to jumpstart your car 40 times a night. That's what obstructive sleep apnea is. Every single time your airway, which is, let's say this is my trachea, and it just closes, when the loss of tone, there's no oxygen going to the heart stops for a brief second, a microsecond. And that's what it is every single time your body wakes up, it's called mini arousals or micro arousals. You don't wake up completely, but people who have sleep apnea, you ask them how they feel the next morning, they're like still groggy and sleepy, even after a 12-hour nap. So the key to treat that is CPAP. Very simple. I know with insurance and all, it's a little complicated, but treatment is very simple. Just a CPAP, okay? So this guy was in the unit. We gave him CPAP, and then his spell stopped. So that was one of the case reports that I had written, and I thought it was interesting for you guys to know with the non-epileptic spell. All right, 3 more videos, and then we'll wrap up after 3 more slides, I think.
Rachel. It's okay. You're back.
And these videos are published by the patients themselves.
Just
I don't have
sort of
to do with
stop for a minute. It's all right.
It's not okay.
I know, honey. I'm sorry.
It's not okay.
Maybe you can play in 1.5x.
Rachel. Rachel, honey.
I can't.
Sorry. You have a staring spell? I missed it. She did?
Rachel. Sorry, it's because part of it is you're scared. All right? You don't have to be scared. We're here. Okay? Why don't you hold her hand? We're here. Sometimes fear
Oh, it's a good
is all the pain. Rachel?
Yeah. So you saw the little this and some staring spell? Yeah? That's Rachel again in the EMU.
Does your arm hurt? Yes? Okay, well, we'll tell him. Let's put your arm down, Rach.
We'll go to the next one. So you saw that brief, about the sound, but that's what she did. Kind of brought her arm up, and then you're like, is this a seizure? Like, to the lay eyes, you're like, I've never seen this before. Maybe it's a seizure.
Feeling good?
That's what I wanted to show you. Sorry about the poor quality here. Sorry. Just to the leftmost side, leftmost down. Did you guys see the third one? Yeah, you saw it. Okay, fine. That's fine. All right. All right, last but not the least. How many of you know what a Pokemon shock is? I know it's a pretty popular game 3 years ago. I don't know, do you guys still catch Pokemon? No? Not anymore. It's not the trend anymore? Okay. All right. So there. Good. I was expecting a unanimous response. I'm surprised some people have said they've heard. Who are the 15% who said they know about this? Please show me your hands. Good. 1, I see. 2. Okay. That's it? 3 there. Okay, good. All right. So, let's go forward. All right. First video. Oh, wait. Before we start. Anybody with seizures here? Epilepsy? Photosensitive epilepsy? Because the video that's about to be played can trigger seizures. Okay? So just if you are, please, okay? Just fair disclaimer. Okay. If it's undiagnosed, it might be diagnosed right now. So, all right, first one. Okay, done. And then play that.
An investigation is underway in Japan into why more than 600 children suffered from convulsions and vomiting after watching a television cartoon program. It's thought that bright flashing lights in the cartoon, Pocket Monsters, were to blame. Andrew Burrows reports.
Almost every Japanese child knows Pocket Monsters and its star, Pakucho. They play the Nintendo computer game. They even sing the Pocket Monsters song. Millions were glued to the latest cartoon episode when a flashing explosion created from these slowed-down images triggered convulsions in hundreds of children. Many were kept in hospital for over 24 hours. Often those affected had no history of epilepsy. More children had fits when excerpts were replayed on the news. Doctors said victims were shocked into a kind of hypnotic trance. Parents are alarmed.
I always thought it was a cute program that was fine for kids. But now I have to be careful about everything they watch.
All right, so some of you have heard of this. Was this the exact Pokemon shock you guys talking about? Okay, good. All right. So this is called photosensitive epilepsy, right? So in the EMU, we do some of the activation procedures for seizures. One of the things I told you was hyperventilation. The second thing I said, we do sleep deprivation. Don't let them sleep the previous night. Evil people, we have to do it. And the third one is photic stimulation. Shine bright lights to trigger seizures, okay? Some memes for you guys. Okay. All right. How many of you know that guy there? Not the two guys laying down, but that guy. Okay. So can you play Cena? Yeah.
Oh no.
I'll tell you.
At the WWE Record Performance Center, nowhere is safe. From the crashes, the bashing.
All right. So, after that break, what is his favorite taunt? Can one of you demonstrate it? Or all of you demonstrate it? Right. Good. Yeah? You can't see me. Okay. So, let's look at the next one. So that was the reason why John Cena had to make an entrance in Seizure case guided review. Okay? Because the kids that have sunflower syndrome, it's pretty rare. It was discovered, I think, a year prior to this. And because nobody knew what was going on, every time they went to the sun, they would have this. And you're like, okay, fine. So the John Cena was the taunt that they get at school. There was another epilepsy which I have not put here, and promise, last 2 minutes. It's called reading epilepsy. Every time a person read something that made sense to him, he would start having seizures. Yes. It's rare. You can look it up later on. It's called reading epilepsy. The interesting part of this is if you give him a bunch of jumbled letters which don't make sense, it would not trigger a seizure. But if something made sense, that would trigger a seizure. Okay? All right. Sunflower epilepsy. So what should you do when you actually see somebody who's seizing? And this is for you when you go to the Mississippi State Fair. I bring this example up because I was there and somebody seized in front of me. How lucky for the patient, right? Yeah. So this is what you do. You stay calm. You know, don't put... In India, I remember people used to give like a keychain in their hand. Some myth that if you have an electrical activity in your brain, you give something here and then it just counteracts with it or whatever. There was no logic to it, but people did it. Their belief was by the time somebody finds the keychain and hands it in to the patient, the seizure's done. Because they seize for 30 seconds or 45 seconds. By the time you find the key, it's almost done. Yeah? So, just lay them to the side, make sure nothing's in their mouth. They're not obstructing their airway, not biting their tongue. Don't put anything, especially don't put your hand in their mouth to hold their, teeth. Done. All right, so the last slide is this year we've kickstarted our sign in terms of we're more active on the social media. I'm the resident advisor of the sign chapter here. So these are the things if you want to follow us. We do a lot of fun stuff. Some of the things that we did was, I don't know how many of you had the chance to do an LP on the mannequin that we did, set up on an interprofessional lunch. So yeah, stuff like that. Okay? And right now, you guys are here. I know they're not the same, but in stage of metamorphosis, you are here. Baby Yoda. I want you to reach there, so may the force be with you. Okay? Questions? We're done?